So I believe most of the panel members are already logged into the voting system, but if you haven't done so, please do so now, either through the Turning Point application or through your web browsers. And if you're having any trouble, please signal Laura. We've got Wi-Fi network information up on the screen as well if you need that. All right, so I've pulled up the test questions, so each of you should now see this on your screens, and you should have 4 options to choose from. All right, so we're waiting for one more response. Oh, there it goes. All right, so let's see. So the correct answer is A, Twinkies. I don't know much about Bear Claw or Cherry Pie's origins, but the cronut is definitely from New York. All right. All right, so with that, I turn it over to Steve.
All right, very well done. Okay, we're just about to launch into discussion of the voting questions. And before I read this, though, I know I wanted to just recognize Joel, who had a perspective he wanted to share just before you guys start to consider the information one more time as we vote. Joel?
First, I want to thank the Institute for valuing the patient perspective. I also wish to acknowledge and thank the committee for trusting me to accurately represent the diverse group of men and their families. Once a man develops castrate-resistant prostate cancer, he and his family are well aware that the future holds bad things. Becoming castrate-resistant is a significant marker that the cancer has begun to change and start on its march that easily lead to a man's eventual death. Men who qualify for all of the drugs that have been reviewed this morning have all passed this significant stage of their disease. The next, and also a more significant marker on this prostate cancer march, is the development of metastatic disease. Metastases are the very essence that makes cancer a dangerous disease. Growing tumors are what cause organ malfunction, eventually leading to the failure of the affected organ. Organ failure and skeletal damage can lead to pain, suffering, and death. Developing tumors, experiencing pain, and eventual organ and bone failure can prevent a man from being able to function in both the workplace and at home. Not only will men be faced with the physical burdens that will be imposed upon them by the inevitable development and progression of their disease, they also are often afflicted with psychological problems and concerns about their health and what they believe will bring about their eventual death from this disease. Men commonly become angry and depressed. This anger can be turned inwards, sometimes even bringing a man to committing suicide. And sometimes it can be turned outwards against their families, their medical providers, and their caregivers. Metastatic disease also directly drives the inevitable and significant decline in the quality of a man's life, in his eventual ability to go to work and to support his family, in his inability to go out and meet friends for dinner, to participate in a card game, to swim in a pool, or even to sit in a movie theater. Metastatic prostate cancer heralds the beginning of receiving treatments that will impact even more side effects than those he's first experienced from first-line ADT. Metastatic disease can cause him to become isolated from the rest of the world because of his inability to walk upstairs, drive a car, get on a bus, sleep in his own bed because of the pain he's experiencing, and even take care of his own personal hygiene and grooming. The argument can be made that drugs that we review today will only delay the inevitable problems that I've just mentioned, nor will they do anything to avoid the economic costs of future drugs, the treatments, and the hospitalizations that will be needed when the cancer does become metastatic. Basically, this argument can best be responded by answering 3 questions. 1, will delaying the onset of metastatic disease ameliorate the severe negative effects like the ones that I've mentioned on the man's quality of life? The answer is a clear and resounding yes. To be able to offer patients significant extra time before they become metastatic is a game changer. Delaying a man's suffering is a gift to him and to his family. The drugs that we've reviewed today delay the suffering. They will also provide many men with great psychological support. By making these drugs easily accessible to all men with M0 disease, men will not find themselves in a position in which they are just sitting around waiting to be greeted by the next bad disease marker, metastatic disease. There are many men who find waiting around and doing nothing intolerable. Men need to feel that they are doing something, even if it's just having a placebo. Now, please understand, I'm not saying that the drugs we reviewed today are placebo or act as a placebo. They're clearly not based on the evidence review. A good example of men's intolerance of just waiting around is that men who are diagnosed with insignificant prostate cancer often choose to get treatment despite good medical advice not to go down this road. Question 2, is it going to be economically cheaper to delay other needed treatments? After all, most men will still use the expensive drugs that will require once they become metastatic. Here again, the answer is a clear and resounding yes. Given the rate of drug development we currently see in men with advanced prostate cancer, and given the FDA's new views on biosimilar drugs, delaying treatments will allow many men to be able to utilize less expensive generic or biosimilar drugs. This could have a significant economic savings. I point out as an example the recent approval of enza as an alternative to Zytiga. In addition, delaying treatment might allow us to be able to utilize newer, more effective treatments that are not yet developed or FDA approved. I tell the men with advanced prostate cancer to lose the word cure from their vocabulary. The most realistic goal for treatment for advanced metastatic prostate cancer is to put the cancer into remission long enough so that they die of something else, hopefully old age. My belief is that this form of cancer, metastatic prostate cancer, is not currently curable. However, I do hold a strong hope that for many men with this disease, that in the future the disease, even when it's metastatic, will be able to be cured. I become hopeful when I look at drugs like Harvoni, which have cured the incurable hepatitis C. I become hopeful when I reflect on the great strides that have been made in the treatment of AIDS. Although we cannot yet cure AIDS, we can limit viral loads, we can prevent transmission to partners and to maternal transmission, all of which save lives, improve people's quality of life, and save dollars, as well as allow people to return to leading an economically and emotionally productive life. Will delaying the onset of metastatic disease extend survival? We don't know yet the answer to this question, for the data that we've reviewed is not yet mature. Yet many of us with this disease are hopeful. The data does reflect trends that indicate that these drugs will extend survival. This fact alone does provide us with hope, which actually is a very important ingredient in fighting this disease. In summary, when voting, I ask the board to consider both the facts and the evidence that have been presented and discussed today. I also want the board to consider the potential effects that this drug might have on the lives of men, their families, and our society when prostate cancer progresses. Many of us patients and many of us advocates do explicitly know that delaying the development of metastatic disease will greatly improve the quality of life for both the men who suffer this disease as well as their families. Thank you.
All right. Thank you very much. All right. So CEPAC, we are now going to be voting on the questions on comparative clinical effectiveness, then potential other benefits and contextual issues, followed by the long-term value for money questions. So for all of these questions, we have a preamble. We are considering the comparator. First of all, the patient population are men with high risk, that is defined by PSA doubling times of less than or equal to 10 months, who have non-metastatic castration-resistant prostate cancer and are being treated with androgen deprivation therapy. So what you're going to be asked is the new drug used basically in many ways earlier. It's the comparator is waiting to add the anti-androgen therapy with either abiraterone or enzalutamide until the development of detectable metastatic disease. So that is the comparator, is waiting and treating when metastases are detected versus treating when there is a PSA doubling time less than or equal to 10 months. We will discuss the fact that the FDA label is broader than that briefly at the end. This is where the evidence is, and this is where we want you to focus. So with that as the comparator and the patient population, the first question is the evidence adequate to demonstrate a net health benefit of treating, and I'll just add the word early, if you will, with apalutamide? You've already discussed a lot of the aspects of this, but now's your chance again to circle back. We have both Greg and David up here if you want to ask again. David, again, you've already addressed this several times, but just real briefly again, the ICER evidence rating for this question and your brief summary of why.
Sure. So again, we rated that we thought we had...
Sorry, you have to hit the button there. There you go.
Sorry about that. We rated this as A. If you look on the evidence packet on page 5, you can see the numbers on overall survival. Again, not quite hitting statistical significance on that 0.7. The time to symptomatic progression, the number we were just discussing that we do have from the Spartan trial, hazard ratio of 0.45, so a 55% improvement in that, highly statistically significant, and metastasis-free survival, the surrogate marker.
All right, so there's a summary again quickly, and let me see if we have questions or comments. Looks like Tim wanted to ask something. Yes.
Do you have absolute risk differences?
We have them for metastasis-free survival.
How about for time? I know it's time to symptomatic progression. Is there any way to get off those curves about like number needed to treat or anything? We didn't have they gave us the hazard ratio, not the absolute numbers on that. So I don't think we have those numbers on time to symptomatic progression. I'm looking over at Patty to see whether... So there's no little n over big N for that?
We don't have that. We have it for metastasis-free survival, and we don't have it for overall survival because the median time wasn't reached in the apalutamide arm. So I can't give you the absolute number, but in some ways that's a good thing. It's because half of patients haven't died yet in the apalutamide arm.
What about, let's say, at 2 years or... I'm just trying, relative is really good, but, I mean, those are pretty impressive relative reductions, but and I guess the modeling...
I think we need to wait until we have the mature survival data. I mean, what you're asking for, we're not going to have for a few more years.
So let me ask this question. By voting yes on this question, am I endorsing a rating of A, which I think there's some conversation that's overstated potentially, and are we suggesting that no additional research is needed in order to demonstrate the net health benefit of this particular product?
I don't think you're supporting the rating of A personally. I think that even if we had rated this B, we would argue that you should vote yes on this. So you can judge that as you like. So I don't think you're supporting a rating of A by voting yes on this.
And in no way are you suggesting that further evidence is not needed to help differentiate its long-term benefits and risks. It is, with the evidence as we have it today, is the evidence adequate to say that earlier treatment with apalutamide provides a net health benefit? Reem?
I'm just going to ask to add to the question compared to placebo plus ADT to remove any confusion about what are we comparing it to, because I think that's what we're answering here.
Well, that's where the data are generated from randomized controlled trials. True. Tim?
So in the modeling studies, did you include any disutilities for falls or fractures? And I saw that the utilities you used, but I'm struggling with using those when the quality of life data from the trials shows no difference. And should I just assume that those aren't mature enough, or why would there be that difference? So I guess that was a two-part question.
So for the fractures, we did include that in the model. There's a 1-year disutility of having a fracture. I didn't put it on the slide, but it is included in the model and should be listed in the report. The second question
was about the quality of life numbers. And honestly, to the extent that I would use those quality of life, we were concerned, if you think about it, that starting the drug early would, in patients who have asymptomatic metastasis, or non-metastatic but PSA numbers going up, would diminish their quality of life, right? You're giving a drug with side effects. And so it was somewhat reassuring that we don't see that in the trials. We're not seeing a diminution in quality of life despite this burdensome drug. I don't have a personal feel for how sensitive the instruments are to pick that up. It is clear that there's more fatigue with these drugs. So although patients aren't broadly reporting diminutions in quality of life, I would focus more on the fatigue that we know is happening than either the fractures, the falls, or the low level of ischemic events. I think the fatigue would be the big one if I were worried about it.
All right. I'm going to try to be cautious with our time available, and we'll script. No, not you. I just want to guide the council because I want to make sure that we do have time for the variety of questions that we have to vote on. Reem, did you have one other thing to say? Okay, and Eric, you're also okay for right now? That's okay? That's all right? Perpetually up, that's okay? All right, I think we will go ahead and take the vote then on this question. You can go ahead and enter your vote, and I will display it. All right, 10 yes and 1 no. Sometimes we have time and specific reason to want to debrief, but given the time and the vast majority in the voting of yes, I think I'm going to move forward. So let's go forward. I will also encourage everybody, both on these questions and those going forward, to try to hold off on your voting until the end of the discussion, because it's not impossible that you will be persuaded otherwise. So the next question, probably a lot of the similar issues have been covered in your minds, but there may be specifically other aspects of the data on enzalutamide. David, would you like to just briefly cover that question before they vote?
Sure. I mean, as you're well aware, we rated that the same way. I'll make 2 specific points on that. One piece of that, we're extrapolating from the time to symptomatic progression number. We don't have it for enzalutamide. We have it for apalutamide. If you don't believe it was fair to crosswalk over between the 2 trials, that might answer your thinking on this. The other is on the quality of life measures. I didn't get into this as I was presenting it, but for apalutamide, they reported it as being stable in both arms, which isn't really the way you'd normally like to see these numbers reported. And in fact, there was just another paper 2 days ago, which again did this from Spartan and apalutamide. Enzalutamide did it the way you would have wanted to see it, which was versus placebo, and showed that there was no difference on quality of life between enzalutamide and placebo. So I'm more comfortable in some ways on the quality of life being comparable in the 2 arms in Prosper than in Spartan.
Okay, so I think you can see in Table 4 on page 5 of your evidence summary again, the metastasis-free survival difference, the hazard ratio, the key issues there. Any other questions? My guess is, again, that you raised the issues that you needed to raise with apalutamide, but anything okay? Please go ahead and vote. All right, 8 and 3. Briefly, perhaps, if we have a sec, because there is some distinction between these 2 votes, would someone who voted yes on the first one and no on the second one describe their thinking? Yes, Jill. And yeah, hit the button, please. Thanks.
Thank you. I voted yes on the first one because when questioning what net health benefit do you get looking at not using the extrapolation that David talked about, or the extrapolation from the meta-analysis of the combined overall survival, I ignored that. So looking at this one by itself, I gave credit to the time to symptomatic progression with an impressive hazard ratio, and enzalutamide doesn't have that, so.
Okay. Anybody else have a starkly different reason that they've switched from yes to no? Thank you. If not, we'll keep going. The third question, so now we're in a slightly different ballpark. Is the evidence adequate to demonstrate a net health benefit of treating, again, I'll say early, just to be clear, with abiraterone acetate prior to detectable metastasis? Dave?
Sure. So this is the one where, honestly, going into the report and on the report, we were spending the most time. We don't have a randomized trial. We have randomized trials in this earlier stage of the disease, where this drug looks very much like enzalutamide in randomized trials in metastatic castration-resistant prostate cancer, which is a continuum of disease. This drug in the IMAGINE study, small number of patients, but looks beneficial. How beneficial is a lot harder to tell without a randomized trial and a comparison group, but certainly looks beneficial in that. Our sense was that it would be surprising if there wasn't at least a small benefit given the data there. So we felt that there was at least a small benefit. You'll need to decide whether you agree with that.
So again, there was one non-randomized study, isn't it the IMAGINE study?
The IMAGINE study is the study in non-metastatic. We have multiple trials in metastatic where it looks like enzalutamide, and apalutamide wasn't around and being studied at that time for us to say whether it looks like apalutamide.
Okay. Russell, if you don't mind, let me just play devil's advocate, because I know this is running through many of the council members' minds. I'm a clinical expert. I'm not really, but obviously I'm going to play one for a second. I know that abiraterone works in metastatic. I believe that this is a spectrum of disease. I see a median time to PSA progression of 28 months, which I know is almost twice what most of the control arms are in the non-metastatic trials. Do I believe that there's adequate evidence that abiraterone acetate works in this population, or do I not?
Well, adequate evidence is sort of a yes or no question, obviously, right? And so let me say this, that before these two trials, what did we do, right? So before these two trials, we either, for patients who are at low risk, they're low risk, we don't worry about them, but for patients who are at high risk, I would try to get them abiraterone or enzalutamide off-label. So I believe that there, even before these trials, was sufficient evidence based on other trials with enzalutamide, based on other trials, based on this trial with Zytiga. So my answer would be yes. Is it as good of evidence? Clearly no, but adequate, yes, in my opinion.
Could I ask Russell a question, please?
Sure.
Xtandi and apalutamide have a very similar mechanism of action, I believe, but abiraterone has a different mode of method of operation. Does that come into your thought process?
It's a great question. It doesn't, only because many of the mechanisms of resistance are the same, and the phase 3 trials in the metastatic castration-resistant setting have very similar hazard ratios with similar patient populations. So I believe that although they do have different ways of achieving the same goal, which is decrease androgen signaling, my belief, based on the data that we have, is that they're both effective.
All right. So, and David, our evidence rating was B+. Yes. All right. Council, questions, perspectives? Greg, you look like you want to say something.
Just remind me, this is not FDA approved, correct? For this indication?
It is not.
That's
Okay.
correct. Tim?
Again, just looking at table 5, just help me if I'm wrong here. There appears to be 6 versus 0 falls, 42 versus 24 hypertension, 34 versus 7 hypokalemia, 25 versus 2 peripheral edema. So it seems like there's more in the AE spectrum. Oh, no, that's not versus. Those are any grades, and that's just in that single, any versus grade 3. That's just in a single-arm trial?
Yeah, and just broadly, my sense is that people on the falls and fractures maybe aren't seeing quite as much with abiraterone acetate, but the other stuff you're seeing there is the adrenal side effects. And those don't happen with the other 2 drugs. That's a problem with this drug, and that's why it's given with corticosteroid.
All right. Any other questions for abiraterone use early versus waiting? All right, please go ahead and vote. All right, 9 no and 2 yes. Since I posed the devil's advocate in a sense in a positive way, could we have a statement from one of the council members who voted no that would help the future reading public understand the majority vote here? Reem?
I think so we have much less data, limited data with the number of patients, but I do think the issue that we give this medication with steroids, all the side effects there, unless it's really nicely compared, it's just really hard to talk about net benefit.
Okay, thank you. Any other perspectives that people would want attached to their no or yes vote on this? Okay. Let's move into 2 more comparative clinical effectiveness questions, and then we'll move to the potential benefits. So this is one of the different forms that we ask a question to help guide policymakers and clinicians and others. Is the evidence adequate to distinguish the net health benefits of early use of apalutamide and that of enzalutamide? The ICER rating, we've heard David say before.
It was an I rating.
Right.
Yeah.
Any questions about
And this
your
goes to
thinking here?
one of Neil's critiques that he raised, correct? I mean, in terms of
I think
the
his
head-to-
critique, and I'll paraphrase for him, but it was, I believe that his view was that distinctions between these drugs should not be made based on the available evidence. He can throttle me later if I got that wrong. I'm pretty sure that would be a fair statement. Any questions for the research team, the clinical expert, the patient? All right, you guys are looking very well prepared for this vote. Please go ahead and vote. All right. Consensus is a beautiful thing. Let's move on to number 5. Is the evidence adequate to demonstrate that abiraterone acetate has comparable efficacy to apalutamide and enzalutamide? Again, remembering all the preamble to this, we're talking about early use in non-metastatic CRPC. Is the evidence adequate to demonstrate that it's comparable? We attached, go ahead, why don't you just summarize what our report said again?
Again, we gave this an I rating. There's a substantial section of the report and in my presentation where we looked to try to see whether we could convince ourselves that it was comparable. I believe that it might turn out to be comparable, but I don't think the evidence is there, and that's what our report says.
And I'm sure it's clear to some of the public, but maybe not to everybody. But these questions are selected partly in response to what we hear are some of the key questions that the policymaker community has. So the abiraterone, as David mentioned, is going to be going off patent soon, and that raises questions about the competitive landscape and the potential use of abiraterone for certain indications. Should it gain a new indication and or should it be viewed as much less expensive and a higher value? So that's why you're seeing some of these comparative questions between abiraterone and the others. Any questions from CEPAC? All right, please vote. I'm guessing we have one person who's locked out
Yeah, that's correct.
of the mechanism.
In the interest of
All right.
I'm going to register my vote.
All right, willing to be a public voter, we have 10 no and 11 no. All right. Do you want to get some help trying to get back in? I'll talk slowly, maybe. Okay, now we're going to move to the potential other benefits and contextual considerations. Now again, this is a little bit tricky because we're asking you to compare early use of treatments that have been used already once the disease is identified as having become metastatic. So we're asking you about the early use. Does it offer potential benefits? I'm going to read through these very quickly. Does it potentially offer reduced complexity in terms of its mechanism of administration usually, or other features that will improve patient outcomes? Will it reduce important health disparities across various categories? Would it reduce caregiver or family burden? Is it a novel mechanism of action or approach? Will it have a significant impact on worker productivity? Does it offer other specific benefits or disadvantages that you wish to name? David, you had one slide in which you quickly summarized some of the early thoughts that we had based on our discussions with patient groups and others. Do you want to just real quickly comment on that again?
The ones that we flagged here, and again, you can always create stories for any of these, for any treatment that's beneficial, but in terms of substantial potential other benefits, I wanted to flag in the report the socioeconomic, racial disparities and whether you feel that the disproportionate impact on black men affects this, and then the issue that you've heard a number of times about having a treatment in the setting of non-metastatic rather than just waiting, and whether that's something under other.
And obviously, Joel gave us a good view from the patient's perspective. Discussion about these issues, and I know some of you are new to these voting questions, so you may have some specific questions, but any thoughts? I also like to encourage people, if you're going to vote in a certain way and you'd like to share your thinking with people ahead of time, it can sometimes be helpful to stimulate people's thinking about how important, whether there's evidence for it, different aspects of it. Eric, and then we'll go
So in this particular case, we've had some wonderful cases that you've brought to us in which there's a lot of complexity and a lot of additional color that we can add to the situation. And I really respect, Joel's remarks. In this particular case, though, I find it difficult to find additional factors, other potential benefits that are not captured that would not be captured by a quality of life instrument. So things like anxiety that might be related to not taking action. Mm-hmm. For example, we should be able to capture through a tool like a quality of life instrument, whether it was successfully done in this approach or not is to be debated. But I'm leaning toward not seeing the potential other benefits, and so I'm asking my colleagues.
Can I just comment on that
Yeah.
one? Remember that those quality of life measurements were done in a randomized trial
Yep.
where people didn't know if they were getting drug or placebo. We're not going to see that particular psychological benefit show up in an RCT against placebo. I'm not arguing that you should think it's a substantial benefit or need to vote for it, but it's not really fair to look at the quality of life within the RCT because everybody's
both took action.
They both took action, and neither one knows for
fair.
sure whether they're
Yeah.
getting a real drug or not.
That's fair enough. That's a good point.
Good. Ryan?
I'm going to just agree with Eric. I will be voting for none of these. I think it's a little disingenuous to say that these drugs will reduce health disparities. As Mr. Nowak mentioned, there are a lot of other factors that go into accessing care, accessing prevention. We know African Americans have a rate of uninsurance that is 50% higher than their Caucasian counterparts, and for African American men, that uninsured rate is even higher. I would like to see the report mention the systemic racism that is a history within our healthcare system. Remind folks that the Tuskegee experiment did not end until 1972. That is within our lifetime. And so I don't think you can say just because there's drugs and there's the availability of these new drugs that means that it will actually reduce the disparities in any way. So I will not mark that.
All right, thank you. Reem, you put yours down, then Tim. Tim, did you have a comment or a question?
Okay.
Yes.
Yeah, so I agree. I'm not going to be voting for any of these, but maybe for a slightly different reason. It's that I'm viewing this as what was presented to me and what the evidence was. And I heard some powerful stories, and maybe that might be true, but I'm looking at it from the evidence report and the modeling perspective. So I think if we want to ask these questions of me as a panelist, I would want to see it in the evidence report itself. And I agree on the disparities aspect. If there's one area of disparities where it's an issue, it's socioeconomic and race, et cetera, and with the cost of these medications, even though they appear to fall within some of our cost effectiveness thresholds, they're going to be a big issue with regard to disparities of care for those who have less access due to financial reasons.
I thought you might have actually raised the possibility that if we're going to treat earlier and therefore start the financial toxicity earlier, it could actually increase disparities. The wealthier would be more likely to start early treatment than others. Greg.
Yeah, no, I generally agree with my colleagues here. As someone interested in mechanisms of action and innovative mechanisms, I give it a point for that, and still hold out some hope that we're going to see, with longer-term follow-up, some harder outcomes, maybe based on the novel chemistry involved here.
All right, thank you. Why don't we go ahead and vote then? This is one where, given the voting system, you're going to enter all that applies, so I just need to wait till you're done. So I will give you a minute and then ask if you are done. You just don't push a button. Yep.
I do think, Steve, that it would be important. Like, I personally think it probably will increase, if I'm to make a guess, health disparities, so somehow reflecting that in the final report.
I think we'll find a way to weave that into some of Ryan's perspectives and reflect that as part of the voting. Is anybody still voting? All right. The results are 3 people voted F, 2 people voted D. It's a novel mechanism of action or approach. Since F is something else, an other benefit, can we just quickly see what that was? It was at this, yes, Stuart.
The disadvantage was the financial toxicity. That's why I voted F. And the advantage was delayed more onerous treatment.
Okay. Don?
Relative to other therapies for prostate, for a variety of different types of prostate cancer stages, the oral form and the relative side effect profile seems to me to make it a lot easier to tolerate.
Okay, we'll go forward to the contextual questions. So here again, we ask some what I would call broader questions of how you think payers and other policymakers should think about value in the context of the available clinical and cost-effectiveness evidence. So are any of the following considerations important for them to take into consideration when assessing the anti-androgen therapy's long-term value for money? A, it's intended for the care of individuals with a condition of high severity in terms of the impact on the quality or length of life. B, it's intended for care of individuals with a condition with a high lifetime burden of illness. By that, we usually mean it's kind of a combination of severity and duration throughout a patient's course of life. C, is it the first to offer any improvement for patients with this condition? At D, there's significant uncertainty about the long-term risks of serious side effects. E, significant uncertainty about the magnitude or durability of its benefits over the long term, or other important contextual considerations. Your thoughts on your initial voting inclinations for these? Questions you'd like to ask clinical expert or patient or yourselves? Yes, Tim.
So this one may be way out there, but I'm going to ask it to Russ. One of the big issues about prostate cancer screening and treatment is we've got to find it early, we got to treat it early, because if we don't, there's no effective therapy for those who have disease spread. To me, this provides some suggestion that that early statement is not true, that we may have some effective therapies for people who have disease that's spread outside the prostate. Do we think it would have any impact on the desire to test and treat all patients with early stage disease? Because you have to treat it now or there's no hope later.
So I wouldn't agree with the statement for a few different reasons, but so we have to detect some early and treat some early. So there's a difference between sort of more indolent, you don't have to deal with it, and the more aggressive disease. And but I think to your point, I don't think this has impact on the fact that we do actually need to treat the aggressive ones earlier, because this is not curative and toxic. So if we can't, it's not horribly toxic if we get, but these patients have already been castrated for a while, which isn't pleasant from what I hear, and this has its own sort of side effects. And so I would think that our goal should still be to detect the lethal cancer before it becomes lethal and take care of it.
All right. Good. Okay, why don't we go ahead? Looks like no one is burning to ask another question about this. So please go ahead and vote. Again, indicate any or all that apply, and I'll give it a minute and then see if you guys are done. All right, anybody still need time to vote? Okay, here are the results. 3 out of 11 for A, 4 for B, 0 for C, 3 for D, 8 for E, and 3 for F. I think the discussion has made most of your perspectives fairly clear. I know that there's a split vote on many of these, but let me just make sure we capture for F if there are specific contextual issues that you feel are really important for the final report to reflect on.
My second question was whether there were differences in how these particular patients died, and I didn't get an answer to that, but it is a question. In other words, and I think we have to look at this as a future question, is the trajectory and quality of the death, if that's a reasonable phrase, different than those that don't receive this treatment?
All right. I'm not sure if I were a policymaker how I would take that into consideration in judging value, but it's an interesting question. Stacy.
So I think when thinking about the long-term value for the money, one of the things that just keeps coming back for me is expanded use beyond the high-risk group.
We're going there.
And also
in the last 15 minutes.
Length of treatment, and I think that the length that was used in these models is relatively short compared with some of the evidence that we were provided in the net benefit. So those are two considerations for other.
Okay. And I will circle back to that issue, by the way, when we vote on the long-term value for money, because I think that was important too. Tim.
So I want to reemphasize the 2 points brought up by Stacy, and for me, it was I wasn't certain about how all the disutilities were incorporated in the modeling, particularly based on single studies and relatively short term that hadn't reached some of their outcomes that I think would be most important for me in those assumptions than the models that I think could move things one way or the other.
Okay, Russell, sure.
Yeah, I was surprised that nobody was a C on this one. I mean, these are the first two drugs in this patient population to gain FDA approval. With the caveat, metastasis-free survival is not overall survival, but is a reasonable surrogate that has been modeled out in a few different contexts. So I'm not a voting member, obviously, but if I was, I probably would have voted C, and I think that it should be brought up that there are no other FDA-approved options in this patient population.
The kind of the common law of how this question came to be and how it's been looked at is it primarily came up to make sure we captured the potential for a disease, an entire disease or condition that had never received any kind of treatment, frequently a genetic disease that has just never been treatable, and now there's something to treat for it. So it's not always just because there's a new indication that doesn't have it, but but different people would interpret that somewhat differently and see the relative advantage of having a new option for those patients. So I'm fully acknowledging of the importance, certainly, for patients who feel like they now have something there.
And just on that,
yeah,
that is what you just said, Steve, was the way we have interpreted. Okay,
right.
So
yes, but I'm
right.
I'm taking it as a friendly amendment that we should not discount that certainly for patients and for doctors, they now have an FDA-labeled drug for the use of these patients for whom before they basically said, wait, or I'll try to get abiraterone off-label for you.
No, I think that's important for maybe those in the audience that haven't watched these CEPAC meetings. That's how we intend to use that item C, and that's kind of how it was developed, and we were trained on trying to reflect that. And when you think about products that have been introduced into categories where there was nothing at all, like the blindness one is a good example.
Yeah. Okay, two more value voting questions. Now you pull it all together. Everything. The comparative clinical effectiveness, your uncertainty around that, the cost effectiveness, your uncertainty around that, your consideration of potential other benefits, disadvantages, and contextual considerations. And now you're asked for a single vote on whether the long-term value for money of, this one is probably apalutamide, if I can find it buried in here. Yes, apalutamide, again, used early compared to waiting to add anti-androgen therapy later. I'll just mention again that, and maybe it deserves further comment, but Stacy, you raised a question that's, I think, going to influence your vote here, which is whether the use of the drug is actually for a longer duration to get the net benefit that was modeled. If that is the case, you would have the expense of the drug for more months that would drive the cost-effectiveness ratio, the ICER, up. And how much further up, Greg, we don't really know. Did you do a sensitivity analysis with a longer duration of treatment?
Yeah, just off the top of my head, though, I can say that it would go well above 150,000 per quality.
Don't do it off the top of our head if possible.
Sure.
I know.
So, and also just to circle back, my understanding is that the numbers from the trial, there was an assumption that we were seeing these short durations because of the duration of the trial, but actually, it affects how you think about this. I think what was going on is that within the trial, there were patients going off the drugs, as happens in a trial, and we saw the median duration. So we should be cautious about going, gee, the median duration should be the median duration to metastasis-free survival when that's not what happened in the clinical trial.
So just to be fair, I'm glad, because I was going to circle back, and you just stated it. I was just going to say the rationale for that being the base case is because it's real. It was what was measured in that study. So we have a certain tension between the perspective of the clinical experts and others who would feel intuitively that they would treat to the median, but we have real data, if you will, that's...
I just raised I don't understand it. I mean, the discontinuation rate was low. The discontinuation due to toxicity was low before progression, meaning. So there's a discordance between those two numbers that I was hoping somebody could explain to me, and that's all.
Yes,
so
Stacey.
I bet you don't need too many people to stop at 1 week
to drive down those numbers, or to only be treated for a relatively shorter period of time to die, to get these medians and averages to change. It's like following people in a trial 0 to 20 years, and you really follow some out to 20 years, but the median survival is much shorter because when they come in or when they die, it really skews things. So standard deviations around that, I think could really make a difference for why it's 18 versus what you're kind of describing in practice.
And Greg, I'm sorry, I usually ask or turn back to you to just quickly summarize the base case findings anyway. But the base case ICER, was this one that was 68 or 80? I forget.
Apalutamide was 68,000.
Okay.
If we, we did the one-way sensitivity analyses, and the highest duration of therapy that we did in the one-way sensitivity analysis, this is just plus or minus 20% of the base case, but going up to approximately 23 months of duration of therapy when the baseline is, what is it? It's, I think, about 16. I can't find it right now. But going up to 23, that brings us above 100,000. If we were to go up to, say, 40 months of duration of treatment, then that goes above 200,000 per quale.
Okay. But up to the median, even if we wanted to push it hypothetically to the median duration, the median metastasis-free survival point, it would be somewhere between 100 and 150,000 per quale?
At the median, yeah.
At the median, okay. Oh, Jill.
So, I mean, I hear what you're saying, and I'm confused on how to vote on this because my answer would likely change. I mean, so do you want us to, or would you put into the final evidence report the caveat of what we're considering here and possibly about how, how the values would change? Because that's a big difference. That's a yes or no difference.
We will do two.
Or low or high.
I think I'm going to suggest two things. One is we will capture that this became a point of discussion, a good question raised for which we don't have a perfect answer. I also think it's fair if we have a vote and you vote one way or the other, and this is consequential in that we'll try to do a quick debrief on that. But I also think we owe it to you to do the best job we can of clarifying the base case assumption and whether the ICER research team feels, again, I'm saying we did pick it as the base case, why we think it was the right base case assumption in this situation. Then it's up to you to decide, which you would prefer or weight in your mind in the voting. We'll note that this is an issue and also try to do a quick debrief. So let me just, again, if I had to turn to Greg, and David, you can chime in again, the reason that you picked this as the base case, and now having heard this conversation, your sense of how you would advise the council to consider your findings, the cost-effectiveness findings, between the sensitivity analysis and the original base case.
I mean, when you're building a model, you use the best evidence that you have, and then you make assumptions where you don't have the best evidence. And for this particular outcome, the duration of, or this particular trial outcome, we had that data, right, and that's what we ended up using. Right. But, I don't think in the process that we heard too much feedback along what Russell is saying as far as the duration of therapy being much longer than that. And so we went with what we had. But if there's a good case to be made that patients are on for longer, then I think that that's a good case to include it as a scenario analysis, at least within the report.
Okay. I'm personally not familiar with a modeling exercise in which they have chosen as the base case duration of treatment that wasn't that documented in the trial through other input. Maybe that exists, but I'm not familiar with it myself. So this would be the standard approach, would be to use the benefits seen from the study data and the treatment duration used in the study data. To do otherwise would not be the norm.
So, because earlier, and maybe this was, but earlier I thought you said that you had modeled it for longer, and then the manufacturers wanted it to match, and you used the words "we gave in to them" on that, or gave it to them on that one. So that didn't seem to indicate to me that it was standard to match what was in the research if you gave in to them on that one.
So my recollection of what occurred on that is as is happening here, our image was you're going to stay on this drug until you progress. And so we were modeling it as you will stay on this drug until you progress because that's the way you're supposed to treat. We got feedback from the manufacturers, not surprisingly, saying, look at what the actual median duration was in the trial. It's great that you were planning to model these people staying on it, but the benefits that were seen in the trial in an intention to treat analysis were based on the median duration that actually happened in the trial. That seems like a fair point. And you can view that as giving in, but it seemed like the right analysis once that was pointed out.
And it's a process, this was early on in the process, early on in the model, which was not finalized at that point in time, and there's a lot of back and forth between all of the stakeholders to make sure that we're getting everything right. And in that early presentation, I guess we hadn't taken a good enough look at the median duration yet, and I think it's a little bit buried in, especially with the Prosper trial, which at the time we only had a poster to go on. The full, was it New England Journal paper was not published yet, so there were, a lot of discussions that had to be had around that at that particular time.
All right, great debate. Sorry. Last comment on it before we vote. Go ahead, Ryan, sorry.
I was just going to say, but there is an incentive from the manufacturer to have the lower.
Absolutely.
Let's be clear. And if that's not the reality that we're hearing from the clinical side, I mean, that's the concern, is that, yeah, okay.
So that's why it's important, from my perspective, that you've heard what the cost-effectiveness ratio, at least the general range, would be if it were marched out to the median length of progression-free survival. Stacy, I'm sorry, I should give you one last word because you raised this issue towards the end, and it's important for you to have
So I guess just thinking about, I understand why using the 11 months roughly would be kind of fair based on what people were doing in the trial, but when you're thinking about the cost, when thinking about starting a person on treatment, you're not recommending that they only stay on it for 11 months. And so it would be nice to see the upper tail of that sensitivity analysis to include the longer length of therapy. I know it's like now has up to 20% increase, but it would be good to know in that context of, the median time to progression or to metastases to see that number.
Sure. I just want to say from an epidemiologic standpoint, though, think about, because we get manufacturers try to do this in the other direction. If we looked at the people who stayed on therapy for the longer periods of time and how they did, they would do better than the average patients in the trial. So it's not fair to just say, oh, they got more costs. They would also get more life years and more qualities, and it would no longer be a randomized comparison. So be really careful about what you ask for here. This analysis is the analysis based on the way the study was randomized.
And now you have it all. All right. Why don't we please go ahead and vote? You get A is low. I always like to make sure that you know the directionality here. A is low. That doesn't mean a low cost-effectiveness ratio, low value. Intermediate value. C is high value. Please go ahead and vote. Usually happens before this, but we've got one. Oh, there it is. Thank you. All right. 2 low, 7 intermediate, and 2 high. You guys are a bell curve today, so that's in. We do have to move quickly, but I'd love to go ahead and try to capture if people's votes, how it reflected something consequential. Let me start quickly with a low value, an ICER of 68,000. et cetera, who would say this is low value? Give us your reason, please.
So I called it low value for all these issues about treatment duration, the way the statement is read. I would have gone to intermediate value if you would have said value of treatment with apalutamide for 18 months compared with waiting. But if we're really treating to the time they have detectable metastatic disease, it should have been modeled as time to metastatic disease. That's what changed
right.
my vote.
Okay. In contrast to high value, two people felt this was high value. Could I ask one of them if there's a specific justification? Stuart?
This is my second ICER meeting, so forgive me for my naivete, but I thought the discussion was swayed too much by the caveats that we discussed at length, which are important caveats. But again, the data is the data until we know more. In answer to Russ's questions, is there data that would clarify this better? And so I felt like it met ICER's characteristics of high.
Okay, thank you. I'm going to move to the last value vote so we have time to talk about brief policy ramifications. So I'm not even going to try to read the whole thing again. This one's about enzalutamide. Same question. The cost effectiveness, again, findings were slightly different on the point estimate, this one was the one that was in the 80s, the ICER. All of the other issues that you've raised are essentially the same. Any specific questions about, or Greg, anything distinctive about the analysis, the long-term value for money, cost effectiveness piece at least, that you think it deserves mentioning here?
Just that the differences in survival and quality adjusted survival are really just a reflection of the very small differences in the hazard ratios between the Spartan and the Prosper trials. So that's what's driving, if we were to compare the two, which we're not, that's why the ICER is a little higher.
Okay, thanks. Unless I see an outbreak, a riot, I'm going to say that you guys are ready to vote. Please go ahead and vote. All right. Believe it or not, I'm not going to ask who switched from high to intermediate. I think the picture is clear enough. Thank you very much for the votes. We have about 5, I might stretch it to 10 minutes, for a last round of brief comments from the clinical expert and the patient representative. If you guys would like to summarize for us what you think are the key takeaways that you would like to send a message to the policy-making or clinical or patient or manufacturer communities. If you had 1 or 2 things that you would ask them to do going forward that would help patients, help the cause of value, if you will, and help us keep the health system overall more affordable, how would you frame those recommendations from your own perspective? Russ?
So I would just have two suggestions or comments. One would be that we need to mandate that there are more hard value endpoints embedded into trials where the primary endpoint is not a hard clinical outcome. A single or 2 quality of life metrics that are sometimes hard to interpret, and in the cases here weren't even reported in the same way, and one wasn't even reported in the standard way, make that even harder to interpret. So I think we need some standards on what those would be. Time to pain deterioration, time to performance status deterioration, time to symptomatic progression. These are things that we need to actually see in order to better interpret value. The other thing that I would suggest is that we now have 2 new large data sets from which we can get better surrogacy endpoints to better inform value. We don't have great data on metastasis-free survival as a surrogate for a clinical endpoint, and they're 2 different companies, but it would be great if we could get them together to better model it as a surrogate.
Thank you very much. Joel, as briefly as you can. Same,
I know that's
same
hard for me. I think, first of all, there's a lot of evidence that there's bias in prescribing, and I would really like to find a way to make physicians more sensitive to their personal bias and that they deliver drugs sooner to people who don't look like them. And of course, we need to find a way to get clinicians into the neighborhoods and clinicians who look like the people who live in that neighborhood. I think that helps a lot for trust. For the insurance companies, we need to lower copays. Men are paying significant premiums, and there's got to be a way. $1,000 a month for a drug is just intolerable. For pharma, I'd like to ask them to find ways to increase and grow their assistance programs, expand them to include more men, and to do a better job in educating the patient community that they exist. There are men who go off and cannot afford the drug, do not know these assistance programs exist, and even though they may qualify. So they're not doing a good job that way. And then I'm going to ask a question for perhaps an additional thought going forward to affect some of the ICER ratings. I don't believe that there's ever been any look at whether primary hormone therapy drugs are really needed or required or have an effect on men once they've gone into the second stage of these drugs, into the second-line hormone therapies. That costs money. Is that necessary? And the answer is I don't know, and so I would ask that perhaps that be a question, a research question that's asked.
Thank you. That's a good point. Okay, so I have two questions to pose because, you know, a lot of the time our work is talked about as influencing the way that payers will think in their own P&T groups or, you know, pharmacy benefit managers. So two questions kind of jumped out at me because they're both kind of stereotypical. One is we have an FDA label that seems broader than the patient eligibility criteria for the key clinical trials. This important issue of the PSA doubling time. So payers may consider whether their insurance coverage would limit coverage to patients who have a demonstrated PSA doubling time of less than 10 because that's where the data are on both effectiveness and value. FDA chose to do something different, which has the potential to create tension for a lot of people. So I guess, Russ, let me ask you, how do you think the clinician community would react if insurers said, look, all the data was on PSA doubling times that are high. We want to see evidence of that before we will approve coverage for early use of apalutamide.
Well, the instinct would be crap another barrier, you know, like another prior authorization barrier. We now have to send it another form and then get prior authorization and then be on the phone. So that's the instinct. And the truth is, it's not that hard to calculate it. There are all sorts of web portals where you put in the values and it spits out a number for you. So I think it would be appropriate, but it would piss us off.
Clinical language, there you go. All right. Joel, do you have a thought on this?
Very simple. It would piss patients off.
All right. I would raise, having been a primary care clinician, I think what's fascinating about this is the tension between appropriateness and pissing people off, because we all know as primary care docs, too, how hard it is for patients to wait. This is the old issue of watchful waiting or active surveillance versus primary treatment, and it seems like it's raising its head here again. So I think clinicians almost have an obligation to make sure that patients are aware that the data were limited to patients who had a rapid doubling time, and correct me if I'm wrong, that there is usually time. It's not like they're going to pop up with a metastasis if their PSA doubling time is much greater than 10. So this is a wait until potential scenario that, based on the clinical data, again, we're not going to suggest whether it's right or wrong, but we're trying to capture the different perspectives on this in our report. So the last quick one is another aggressive action, some people would view it, that payers could contemplate is two drugs with very similar mechanisms of action, apalutamide and enzalutamide. They even almost sound like they're the same drug. If a payer could negotiate a much lower price and pass some of those savings or all of them on to patients, would the patient and clinician community, how would they react if only one of these two drugs were available on the formulary? If payers went out and said, great, these two drugs look like they act the same, the benefits seem the same, the side effect profile is virtually indistinguishable, I'm going to negotiate the heck out of this to get the best price, and that will require that I offer one of these two companies all my business. What about that?
I think if the savings was passed on, then it would be well received, but too often it's not. So I'll tell you that, these types of things have been happening with abiraterone and enzalutamide for a long time. And my feeling is that the copays that patients see once things are approved don't necessarily reflect the differences. So I think if it was you can only get one, but your copay is going to be $50, great. But yeah.
I actually would be concerned about one thing. We don't know we know that within abiraterone and Xtandi that they cause resistance to each other. However, there are a percentage of men who do get a positive effect after having had developed resistance in the other drug. So we also don't know relationship between apalutamide and Xtandi, although they are very similar. We don't have evidence that talks to us about resistance from one to the other. So on the surface, I like the idea. However, we may in fact be denying men from a drug that will give them a benefit, so I'd be concerned about that.